All right, next we're going to get into cardiogenic shock. Share my screen. All right, so this is video number 4, cardiogenic shock by Kyle Ortega. So what is cardiogenic shock? Critical condition where the heart is unable to pump enough blood to meet the body's needs. So it occurs after a severe heart attack and other cardiac issues, leads to insufficient blood flow and oxygen delivery. So decreased cardiac output and evidence of tissue hypoxia in presence of adequate intravascular volume. So to distinguish between cardiac and cardiogenic and the hypovolemic shock. And then it's the leading cause of death in those acute heart attacks with mortality rates as high as 70 to 90% in the absence of aggressive, highly experienced technical care. All right, so some of our physical exam findings with cardiogenic shock. The skin is ashen or cyanotic and cool. Uh, Dyspnea, so difficulty breathing. Peripheral pulses are rapid and faint and may be irregular if arrhythmias are present. Jugular venous distension, and crackles in the lungs are usually, it's not always present. Peripheral edema may also be present. Low pulse pressure. They're going to be tachycardia. So also, just like all the other shocks, it seems, altered mental status and decreased urine output. All right, so signs and symptoms: low blood pressure with hypotension, absence of hypovolemia, um, pretty much clinical signs of any clinical signs of poor tissue perfusion. Um, Chest pain is very big in this type of shock, as well as that severe shortness of breath, and then as well as that rapid or weak pulse. All right, so the imaging studies that we'll be looking at to really diagnose cardiogenic shock, echocardiography to establish the cause of the cardiogenic shock. Use the ultrasound to get a real good look at the heart. Chest X-ray is going to be useful for excluding other causes of shock and chest pain. Ultrasonography, so they can guide fluid management. Coronary angiography for patients with myocardial ischemia or heart attack who also develop cardiogenic shock. And then it just helps assess anatomy of the coronary arteries. And then an EKG to really identify signs of heart attack or arrhythmias. Um, they also may perform a TEE, to get real-time images, more info about the heart function as well in cardiogenic shock. All right, so moving on to hemodynamic monitoring. So again, we're going to use that Swan scans to help exclude other causes and types of shock. Again, we're going to measure that cardiac output, pulmonary artery pressure, blood pressure, pulmonary capillary wedge pressure. And also, we're going to be using that central venous catheter, which measures that central venous pressure. In my research, it did say that a pulmonary capillary wedge pressure above 15 and then a cardiac index below 2.2 is a pretty much cardiogenic shock. So this is a big factor I found in research that really makes cardiogenic shock stick out hemodynamic wise. Also, you're going to see decreased cardiac output, decreased SATs, increased heart rate, increased central venous pressure, as well as increased systemic vascular resistance. So pretty much it's increasing that myocardial work and oxygen demand. So how are we going to treat it? We're going to use inotropics, just to help that heart out. Dobutamine, vasopressors, to see if we can help that blood pressure. Norepinephrine, Diuretics will really help with fluid as well. And if it's a heart attack, aspirin and heparin, and then also just pain management and helping the patient be as comfortable as possible. And then in some cases, coronary artery bypass surgery will be needed. All right. Next, we're going to be talking about arterial blood gas abnormalities and mechanical ventilation. So, with cardiogenic shock, pretty much see just hypoxemia, hypercapnia, metabolic acidosis, highlighted by that decreased pH. Um, Talking about mechanical ventilation, the research I looked at, which by the way, this looking at mechanical ventilation for all these shocks, it's really been time consuming. But I did find for a cardiogenic shock, AC assist control, whether pressure control or volume control really work well for this type of patient. FiO2 at 100%, and then just titrating the sats up to above 92%. Respiratory rate somewhere between 10 and 20 with tidal volumes between 6 and 10 milliliters of kilograms of ideal body weight. PEEP between 8 and 10 centimeters of water pressure if that PCWP is above 15 millimeters of mercury, like I was alluding to earlier. So, and then also you want to consider inhaled nitric oxide if there's alveolar consolidation, which would improve the ventilation perfusion mismatch. All right, so our concerns with positive pressure ventilation, it can further decrease cardiac output. I did find in the research, it did say avoid SIMV mode. It can lead to swings in intrathoracic pressure with increased afterload and patient dysynchrony. With that fully unsupported breath, it could just swing that pressure a lot. So definitely want to avoid that. And then and that could probably help um, along with that bottom point about exacerbating impaired hemodynamics, which affects blood pressure and cardiac performance. All right, so to summarize all this up, cardiogenic shock basically means the heart doesn't work. Hypotension, severe shortness of breath, chest pain, pretty much highlight signs and symptoms. Hemodynamic wise, you're going to get a decreased cardiac output, decreased sats, increased heart rate, increased CVP, PCWP, pulmonary capillary wedge pressure, increased systemic vascular resistance, and increased blood pressure. You want to treat it with inotropics and vasopressors, which support heart function and blood pressure, and then diuretics to reduce the fluid overload. And you want to increase the PEEP if pulmonary capillary wedge pressure is elevated. So that wraps up cardiogenic shock. Like I said, I'll have all my sources at the end of my next video. So thank you for listening, and I will stop the recording.